Welcome back to the What's in Your Head podcast. I'm Pete Schultz, doctor of physical therapy. Today, we're talking about the different types of low back pain we commonly see in physical therapy. One of the biggest misconceptions about low back pain is that all back pain is the same thing, but in reality, low back pain can come from many different systems and mechanisms. Discs, joints, nerves, muscles, movement sensitivity, instability, fractures, even increased nervous system sensitivity and protection. Today we're going to break down some types of the most common low back pain presentations we see in the clinic, including disc herniations, sciatica, spinal stenosis, muscle strains, SI joint pain, pars fractures, chronic or neuroplastic pain. We'll talk about what these conditions typically feel like, who tends to get them, and some of the misconceptions surrounding them. And as always, this podcast is for educational purposes only and should not be considered individualized medical advice. If you're having severe symptoms, progressive weakness, changes in bladder function, or other concerning symptoms, make sure you seek appropriate medical care. One of the biggest misconceptions about low back pain is that it's all the same thing. In reality, low back pain is a broad category with many different drivers and presentations. So if you have pain, some of the questions you might ask yourself, is this more disc related? Is it more nerve related, joint related, movement related, load related? Or is this the nervous system just becoming more sensitive and protective? And often the answer is it's a combination of everything. Many people don't fit into one box, just like many of the other injuries that we've discussed. Pain can involve overlapping mechanical, inflammatory, neurologic, behavioral, and nervous system components. A recent review on low back pain emphasized that low back pain is best understood through overlapping pain mechanisms rather than one single structural diagnosis. So let's break down some of the common causes of back pain. The first one we're going to discuss is the lumbar disc herniation. Lumbar is your lower back. So they're the 5 vertebrae that make up the lower back or lumbar spine. A lumbar disc herniation usually occurs in adults between 30 and 50 years old. It's slightly more common in men, and most cases improve without the need of surgery. Typical presentations are low back pain with or without leg pain. Commonly, we get pain into the buttock or down the leg. It's often worse with sitting, bending, lifting, coughing, sneezing, or straining. Pain may travel into the buttock, posterior thigh, which is the back of the thigh, the calf, or the foot. Sometimes it follows a classic nerve root distribution, and sometimes it doesn't. All nerve roots have a distribution that they commonly present, like L5-S1 is more towards the big toe or the foot. L4 might be the outside of the calf. There are some typical presentations or distributions that these nerves have, but they don't all follow those presentations, as we'll discuss soon. It may include numbness, tingling, weakness, or changes in reflexes. And a straight leg raise test or slump test may reproduce symptoms. And these tests basically put your nervous system in a position of stretch. If you stretch the nerve, it'll increase these symptoms when you have a lumbar herniated disc. And the most common levels are L4-5 and L5-S1. When people hear the words disc herniation, they often think it automatically means severe damage or inevitable surgery, but that's not necessarily true. Many people have disc bulges or herniations and showing on MRI, and they have absolutely no pain and no symptoms. So the important question is not simply whether or not you have a disc abnormality. It's whether the imaging actually matches the person's symptoms and their clinical presentation. One study showed they took asymptomatic military recruits, and they found that 67% had some type of disc abnormality on MRI having no symptoms at all. They took healthy 20-year-old adult men and women that were joining the different military academies, and they found most of these people have herniated discs and disc abnormalities on MRI, and these are people who didn't express any symptoms at all. So this is important because it reminds us that image findings alone do not automatically explain your pain. Another interesting study was a 10-center MRI reliability study where they took the same person and they went to 10 different facilities to get an MRI, and that MRI was performed and interpreted by the different radiologists at the centers. And the interpretations varied significantly depending on where they had the scan done and who was reading the scan. One radiologist may emphasize a disc bulge, the other one may focus on the degeneration, another may describe findings different altogether. And there were so many different symptoms. So that does not mean the MRI is useless. MRIs can absolutely help identify important pathology, but it does remind us that imaging has to be interpreted in the context of the person sitting in front of you, not in isolation. We use the MRI to kind of get a picture, an idea, but it doesn't always tell you the whole picture. That's why understanding your symptoms and what's going on is the most important thing. Well, disc herniation can sometimes irritate a nerve root, and that brings us to the next category: lumbar radiculopathy or sciatica. Well, a lot of people, they have sciatica. That's kind of like a common presentation or a common word they use. And really it just refers to pain that is somehow traveling down your leg, down the back of your thigh or down your leg. So the most common demographic for lumbar radiculopathy often begins in midlife. Men are commonly affected in their 40s, while women are more commonly affected in their 50s and 60s. The typical presentation is leg pain, usually more dominant than back pain. So the complaints are more down the leg than localized to the lower back. The symptoms are described as burning, electric shocks, sharp tingling, numbness. Symptoms often follow nerve root patterns, but sometimes they don't. Usually the L4 pattern might be around the knee or the outside of the lower leg. L5 might be the top of the foot. S1 is more the back of the foot. These are common nerve root patterns from these symptoms, but we have to look at everything together. We have to look at the MRI. We have to look at how the person moves. We have to look at what symptoms they're describing. And that's why a good physical exam by a healthcare provider is very important when you do have back pain. Lumbar radiculopathy symptoms may include weakness or changes in your reflex. You may lose reflexes, or they may become hyperreflexive with especially the knee patella tendon reflex or the Achilles reflex. And it gets worse with nerve tension, and also can be caused by a disc herniation, stenosis, narrowing of the openings where the nerves come out, or inflammation. Radiculopathy means a nerve root is irritated or compressed, and sciatica is really more of a symptom description rather than a true diagnosis. It describes pain traveling down the leg, but the reason for the irritation can vary. Now let's talk about lumbar spinal stenosis. Lumbar spinal stenosis usually happens in adults over 60 years old, and it's due to degenerative changes and degenerative narrowing of the spinal canal or the foramina. The foramina are the small openings outside of the spine where the nerve roots exit at each level. Typical presentations would be pain, heaviness, cramping, numbness, tingling into the legs, any symptoms down the legs. And it could be on one leg and it could be on both legs. Also, there may be some claudication pain with walking. It's usually worse, and this is really important, worse with standing and walking and better with sitting, which usually worse in an extended position where you're standing, walking, lying flat, any extended position, and it's usually better when you bend forward. And that's why people who have stenosis are usually kind of hunch forward into that position, or they walk in a hunch forward position. Like I said, it's better with sitting and forward bending. People will say things to me like, I could ride a bike and I could sit down for a really long period of time, but I can't walk very far. Or it hurts when I stand up for long periods of time. Standing bothers you more than sitting. Stenosis is often less about one painful movement and it's more about walking or standing, prolonged positions of extension. Patients often describe the legs as feeling heavy, weak, tired, or painful after being in an upright position for a period of time. The next type of lower back pain would be a lumbar strain or sprain. So the difference between a strain and a strain is usually a tear, small tear to the muscle, and a sprain is more a small tear or injury to the ligament. Muscles actually are fibers that move your vertebrae, they move bones, they move joints, and ligaments basically hold the segments together. They stabilize and they hold the two levels together. So lumbar strains and sprains commonly happen most commonly between 20 and 40 years of age. There is usually local low back pain. The pain usually is around where the injury is. So if you have a lumbar strain to a muscle on the right side of your low back, it kind of hurts in that area, the area where you had the injury. It often occurs after lifting, twisting, certain types of sports, doing yard work, or any type of awkward posturing. After the injury, there's muscle spasm and guarding and stiffness, and the pain usually stays in that area where you injured it. It's worse with movement and transitions, kind of getting off the floor, getting out of a chair, getting in and out of bed. Some of the classic things that I hear is I threw my back out. I went to pick something up and my back went out. That might be a typical presentation or something I hear when someone has a lumbar strain or sprain. It's usually caused by lifting, twisting, or doing something. The next type of lower back pain is due to lumbar hypomobility or segmental stiffness. Well, these are people who just really sit at a desk for a really long period of time and have some postural issues where their upper back seems to get a little more hunched or the lower back seems to get a little bit more extended. So this is common in sedentary adults, desk workers, some older adults, people who, after they had a pain episode, they stop moving. And if they stop moving because they don't want to exercise, they get stiff. And it might just be for a body type that tends to be more stiff. Some people just happen to be more stiff and they don't move well. The typical presentation of lumbar hypomobility or stiffness would be stiffness or achiness, limited extension and rotation and side bending, very limited in their range of motion. It's usually worse after sitting down for a long period of time, like at the movies or driving a car, and they get up and they're just really stiff and can't move. It's better after warming up or moving. With this type of person, I like to do a nice warm up, get them moving, get the back moving, have them ride a bike, have them, and maybe even not ride a bike because they're sitting all day. Maybe walk on a treadmill for 5 minutes, warm up your tissues, get your lower back moving in different positions. Well, this person usually will say, once I get moving and loosen up, everything starts to feel better. And it's often not a major tissue injury, but it's the reduced movement that causes some of these symptoms. Now, opposed to that, the another cause for low back pain would be lumbar or SI joint instability. SI joint instability is where the joints move too much. The last thing we talked about was the hypomobility, but this is a hypermobility or an instability where the lumbar spine or the SI joint moves too much. And this is most common with women after they give birth or postpartum patients. Some people are just hypermobile. double jointed, hypermobile. Their spine moves too much. Their hips move too much. These are people who could do splits. They could twist their arms behind their back, could be contortionists. They just move too much. You'll often see this a lot of times when they come in and I start assessing their motion. They'll go and they'll put their palms on the floor. But when I tell someone to bend forward, you should be able to touch your toes, but you shouldn't be able to palm the floor. We used to think that was a good thing, but now we understand that too much mobility or too much movement isn't necessarily a good thing, because you really need strength in that extra mobility to protect your spine. Hypermobile patients, they move too much. Sometimes you see these in athletes, and sometimes it's people who are just really flexible. Typical pain presentations, they get pain near the SI joints, which is the outer portions of the sacrum where the pelvis meets the sacrum. They get a lot of pain in that area and into the buttock. They get a lot of catching, slipping, locking. They feel unsteady. They feel things moving. They feel things pinching. It's usually worse with single leg loading or weight shifting, worse with stairs, twisting, maybe lunging, like elliptical machine, something where their pelvis is rotating or twisting. They could get pain with rolling in bed or prolonged standing in a shifted position. So when we talk about instability, we're usually not talking about the spine dangerously collapsing. More commonly, we mean it's poor load transfers. These people, they don't have the strength to be able to dissipate those forces in their spine. And it's more of a motor control issue rather than a flexibility. A lot of times, people who have hypermobility, they always want to stretch. They always feel like they're tight. With these people, it's they feel much better when they strengthen and they do core exercise rather than when they stretch. But they always do want to stretch, because that stretch creates a false sense of stability, because it puts some pressure or stretch into that system. The next cause of back pain we're going to talk about is spondylosis, or a pars interarticularis fracture. These are most commonly seen in adolescent athletes, people who are still growing and playing a lot of sports, especially involving sports with a lot of twisting, extension, and rotation, gymnastics, baseball, tennis, like anything where you're really extending and twisting. Baseball, gymnastics, football, wrestling, dance, tennis. Typical presentations are focal low back pain. It's a sudden onset. It doesn't necessarily have to be caused by one particular motion or injury. It usually builds up over time. It's more of a stress-related fracture, and it's usually very localized to one spot, and that spot doesn't change very much. When you bend forward or backward, it might hurt even more, but it's always in the same spot. It's worse with extension and rotation. It's worse with running, jumping, batting, pitching, serving in tennis. And those are the things that tend to aggravate symptoms. There's usually minimal neurologic symptoms. It's very local. You won't commonly get pain or numbness or tingling or anything going down the leg. And it usually occurs in teenagers. If you see a teenager, or you are a teenager, and you play a lot of sports, and you get this sudden onset of lower back pain that just doesn't change much and doesn't go away, and it really hurts, I would get an x-ray. I would go to a doctor, get an x-ray, MRI, CAT scan, go to a doctor, go to a healthcare professional, get some imaging just to make sure that you don't have this type of fracture. Now we're going to talk about chronic low back pain, or neuroplastic or nocioplastic pain. This goes by a lot of different names, right? We could call it neuroplastic, nocioplastic, chronic pain, TMS. These are all this is really where you've had back pain and you've had this injury, and it lasts longer than the normal healing time that pain should last. So these are typically for people whose pain lasts more than 3 months, and then you get a nocioplastic type of presentation for this. The pain lasts longer than expected tissue healings. Symptoms may fluctuate and become widespread. It may go from one side of the back to the other side of the back, from one leg to the other leg, to the feet, up to the neck. This type of pain travels more. The pain may increase with stress, fear, poor sleep, inactivity, any type of emotional threat. Image findings usually don't make sense, right? You may have like some disc presentation on an MRI on the right side, and you may have pain on the left side. Typically, with nocioplastic pain or these chronic type pain syndromes, the imaging doesn't really make sense. And there is a lot of hypervigilance, guarding, and fear avoidance are common. The most important thing to know about this type of back pain is it's real. It hurts just as much as a fracture and just as much as a nerve compression. Pain is pain, and pain feels the same, and it's real, and it's not made up, and it's not make believe, and it's not in your head. It's not fake or imagined. Just it's really an injury to the nervous system. Your nervous system has become more protective and more efficient at protecting you and creating pain. And the treatment is a little bit different, right? When your symptoms are lasting, and what happens is when you do have, if you have a facet joint pain, or if you have a hypomobility or a lumbar strain that lasts longer than 3 months, it becomes nocioplastic. The pain system becomes overprotective, and there's just a different way to treat it. You have to start looking at treating the nervous system a little bit more in this case. And like I said, there's a lot of overlap between all of these presentations of pain. Even when the tissues themselves may no longer be significantly injured or damaged, you still get this pain, and sometimes the pain is even worse. That's really with nociceptive pain or nocioplastic pain. The goal of a good physical therapy or a good healthcare evaluation is not simply to label someone with a diagnosis. It's to understand what the symptoms are and take a look at everything. You're looking at the imaging, you're looking at how the person moves, you're looking at what's going on in the person's life, you're looking at the mechanism of injury, of what their body type is like. Sometimes it's a primary tissue irritation, sometimes it's nerve irritation, sometimes it's movement sensitivity, sometimes it's a nervous system sensitization, and very often it's a combination of all of these things. That's why no two people with the exact same MRI could have completely different experiences. Everyone is a little bit different. You could have the same exact MRI and you could have the same disc on a film, but you could have completely different presentations because everyone is a little different, and back pain has to be you really have to look at the whole entire person, not just an image. And one person may have severe pain and disability, and the other person may not feel anything. And it doesn't mean that one person's stronger than the other person or one person's more mentally stable. It's just everyone's nervous system responds a little bit differently. Thanks again for listening to the What's in Your Head podcast. And if you're looking for physical therapy evaluation for pain, dizziness, headaches, concussion, vestibular issues, you could learn more at dynamicsportspt.com. And if you're looking for information on education, tools related to pain and dizziness, please visit pain&dizzy.com. And as always, this podcast is for educational purposes only and not individualized medical advice. And if you found this episode helpful, we really appreciate that if you subscribed and shared it with someone who may benefit, and leave us a 5-star review. Thanks again, and I'll see you next time.